Good morning.
You can hear me and see me,
I can.
and then some, but we won't tell. Good morning, Dr. Rosensweet.
Hi,
Nice
Carol.
to see you. And as I always say, welcome to everybody who's coming up. I know we have a lot of new women here, and I really, really want to welcome you guys. So, question number one. Everything okay?
Oh, yeah.
Okay, good. Um, we didn't get to this question last interview, so I'm going to ask it first. How is it, Dr. Rosensweet, if a woman is very, very low in estrogen, she can still be considered estrogen dominant?
Yeah, good question. Um, well, a woman's hormones peak at the age of 20, plus or minus 2 years. That's the highest they're ever going to be. And they decline over time, so that in her 30s, sometimes that decline's significant. So her estrogen output is highest at the age of 20, plus or minus a couple of years. So's her progesterone, their maximum. And then they decline over time. And then they decline so much eventually that there's not enough to have a period. Now, estrogen and progesterone are in delightful balance, miraculous balance. Estrogen stimulates, progesterone quiets. So, women who do not have enough progesterone, they get overstimulation from the estrogen. And that's where this term estrogen dominance originated. Instead of having balanced situation, the progesterone's not there, and you get the estrogen effects. Even when you're not 20, even if you're 30 and your progesterone's not meeting the same level as estrogen is, no balance, estrogen symptoms dominant. Estrogen effects is what dominance. When you say estrogen dominance, it means estrogen symptoms, estrogen effects are dominating. Estrogen stimulates, I know I'm repeating myself. Estrogen stimulates breast glandular tissue. Every month, a woman prepares for possible lactation. So her breasts get fuller. And she even gets new breast glandular cells. If the progesterone balance isn't there, she's getting breast stimulation, she can get breast tenderness. Estrogen stimulates the uterus, including the uterus lining. If she doesn't have the balancing progesterone, she can get uterine cramps and PMS. Estrogen dominance. Really, estrogen effects are dominating because you're not getting the balancing effect of progesterone. Well, here's a factoid that plays into this.
Factoid.
Age 20, highest level of estrogen and progesterone that there is. Let's have this be estrogen. Let's have this be progesterone. Or I guess I've done that backwards. Do you think they both decline at the same time, simultaneously, in the perfect balance? No, they do not. It's a very common scenario that the progesterone is declining faster and deeper and earlier than the estrogen is. Why is that? We don't know, but it is happening. So you get a lot of women in their 30s who they're starting getting overstimulation by estrogen, or thus known as estrogen dominance, even though their estrogen's lower than it's ever been. They don't have the balancing progesterone. That's how that works. So what's the remedy? And this is the most important thing. Get thee to progesterone early on. And there are over-the-counter progesterones. I mean, I love our progesterone in organic oils. That's my favorite way to deliver it by far. But you can get some decent over-the-counter progesterone before you get your whole perimenopausal and menopausal professional alignment, professional associations, In other words, that you find a healthcare provider that really has interest in education and experience in treating women in menopause with compounded bioidentical hormones, because they're going to eventually, you're going to need someone to write you a prescription for the estrogen and for the progesterone. But in the meanwhile, let that estrogen dominance be the signal of, oh, I want to get on this train called, let me figure out what my body needs for hormones and link up with the professionals and get this one right ASAP. Because the earlier you start getting these hormones balanced, you're going to love it. You're going to look back someday and go, look at that. I started in my 30s. And if you're starting in your 60s, no fault, no foul. Start in your 60s or your 70s. But if you start in your 30s, when that first signs of estrogen, quote, dominance, there's no human being or fairy or gnome that's
I
dominant.
have a fairy and a gnome right here. They might challenge you.
That's actually doing the dominating. It's such a strange term. The estrogen gnome is dominating the scene there.
That's very funny.
So if you do start treating yourself with progesterone early on, read our book, Happy Healthy Hormones. You're going to get much more detail about that. And here's your job. It's always the same job. For any woman who's starting to feel overactivity from the estrogen because it's not being balanced by the progesterone, you're starting to get symptomatic in your 30s or your 40s, you have one job, one main job. Go shopping. Find yourself a licensed healthcare provider. That would be a physician, a nurse practitioner, a PA, a prescribing compounding pharmacist if you're in a state that allows that. Someone who's really taken on the education, because you need extra education to treat women properly in menopause. A lot of it. Well, there's a lot of folks out there who are doing that. They're getting educated. They're going to seminars. They're doing our program. We have that's one of the main things I do is I train and mentor physicians and nurse practitioners on how to do this excellently. Find one of these folks, get a professional, go shopping, see one that you like, and that's what your job is. When you start getting, quote, estrogen dominance, yeah, start the process, because if you get it right early on, it'll take you a while to get it right, especially in the perimenopause. You're going to thank yourself when you're 50, 60, 70, 80, 90, and 100. You're going to go, God, I'm so glad I did that. I had a busy life. I had a lot of different projects going on. I didn't have, quote, time for anything extra, as none of us seem to do. But you know what? I shifted my attention when I was 36 to addressing the hormonal situation. And by God, I put in the time and energy and commitment, and I did that. And oh my God, I'm so grateful in my 60s, 70s, 80s, 90s that I did that. Oh my God, it's the best thing I ever did as far as health choices. So that's my recommendation. Go shopping.
Absolutely, and it can seem a bit frustrating for a moment, but you can do it. I know you can do it, because if I can do it, anybody can do it. Let me tell you. Oy vey. So thank you very much for that answer. I get that question a lot.
Here's
So
a question that popped up. Do you see it from V?
oh, I do. Yes, sir. How do xenoestrogens play into the estrogen dominant?
Yes, and also from Vivian.
Yes, I thought, if I begin at 48, is it good?
I'm going to start with Vivian.
Okay.
48 is fabulous. Not good, fabulous, marvelous, fantastic. It's an ideal time.
You like it?
I do, because by then many women, not all women, they're starting to really notice that there's issues. And so it's inspiring. You let those symptoms inspire you to go out and get it done right. Now to V, xenoestrogens. Well, they're definitely playing a role. And I'm going to shift to the problem that they are creating. Xenoestrogens. They're, our body works with hormones in a very specific way. You got the hormone, and then in the cells, in the nucleus of the cells, there's these receptor sites. So the hormone, like estrogens, for example, travel to the cell and get in the cell and even get in the cell nucleus, and they meet up with the receptor sites. And that combination, hormone within the receptor site, that causes the actions that these hormones that are the most powerful biochemicals in our body actually accomplish. And they accomplish a lot of stuff.
Yeah.
Well, the hormone itself is not the only thing that can link up with the receptor site. An estrogen receptor site, for example, the thing that binds most excellently with it is estrogen. It's designed to receive estrogen. And so when you got estrogen floating around near that receptor site, the affinity is the strongest for estrogen itself. It's not the only thing that will bind into an estrogen receptor site. Progesterone will even. Not nearly with the avidity, if that's such a word. Avidity?
Avidity.
Avidity that estrogen does, but progesterone will bind in there. Well, that's not the only thing that binds in there. There's lots of stuff that binds in there, including stuff that doesn't belong in there. And we are exposed to so many things that so many toxins, really, they're adverse to our body. There's chemicals that we're exposed to every day that can cause trouble. And these toxic chemicals that you read about and you hear about, and toxicity, there's thousands and thousands of them, and we're exposed to them every day. And one of the things that they do, can you believe it, is some of these toxic chemicals bind to these receptor sites. And that's what xenoestrogens are. There's funky, foreign, have no business being in there chemicals, xeno, and they bind to estrogen receptor sites, and they cause trouble.
Well, the real estrogen then can't get in because
there you go. There you go. And you got this false binding situation. This kind of toxicity really calls for something here. And the problem with these xenoestrogens is it's not like swallowing a glass full of arsenic, in which I guess, though I've never heard of any, or hemlock, you pager, you drink a glass of arsenic, and the Yiddish term is pager. You lose it. You leave Earth. You die.
Pager. Asta.
Am I right about that?
As far as I know, yes.
Okay. Two non-world experts in Yiddish. Those are very harsh and intense chemicals, arsenic, and the results are pretty strong and pretty immediate if the dosage is proper.
Asta, and that is Yiddish too.
So many of these environmental toxins, they all are adverse. They all cause trouble, but they don't cause something in the moment that's so identifiable. So you breathe in your dry cleaning fluid that's outgassing from you just sent your things to the dry cleaners and it's outgassing, and you breathe it in, or you're spraying one of those household chemicals on your whatever and to clean up your whatever, and you breathe that in, or you sit on the toilet seat where you sprayed it on there. And these things don't necessarily knock you out cold right in the moment, but they all add up.
Right, like spraying the wood with that stuff that makes it all shiny, carpets,
everything.
A host of stuff, right?
So here's the remedy. Save yourself a tremendous amount of money and time. In my home, what we use to clean is clear distilled vinegar mixed with water. 95% of the time. We use free and clear dish soap, laundry soap, and we don't have a lot of other stuff. If I really want to do something intense, I'll do peroxide.
And it works.
It works beautifully. You don't need all this crap.
It doesn't cost very much either.
Exactly.
It doesn't.
So, because there are so many chemicals, and it's time to reduce your exposure to them, and so that you don't get these xenoestrogens. And the biggest source of xenoestrogens is coming in through the food supply.
Yeah.
Think what kind of chemical strength you need to kill a fungus or a weed or insects on crops. It ain't fairy dust that knocks these critters off.
No, those gnomes aren't doing their job either.
Eh, it's very, very strong chemicals to be able to kill these things. And they're spraying it on agribusiness food supplies because the farming methods of agribusiness are really faulty, which is very different than organic farming methods. So, what's it going to call for you to do? Organic, organic, organic. You need to get organic. You know, the only disfortunate thing about it is the more costly, but in the long run, it's not, because these xenoestrogens, they're creeping in there. So many of these, what does it take to kill an insect or kill a weed? Some derivation of petrochemicals, and these petrochemicals, that means they derive from petroleum products. They act as xenoestrogens when they get into your body. So I'm glad this question has come up, and man, we want to clean up our act and just and save money in the process.
You
Yeah,
know, it's something
the
I'm
money
learning
you
in
save on
school.
all these chemicals, that'll help you purchase the organic. You got to go organic. You got to do what it takes, because I promise you, you're going to want to be healthy when you're 80.
Oh, yeah.
Want to have neurodegenerative disease, because these things are toxic to the nervous system and the immune system and everything else. You're not going to want to have these things add up for decades that you're doing day in and day out. Your life is going to matter as much to you when you're 80 and 90, if you make it that long, as it does now. So these kind of precautions in which you clean up your environment and your exposures save you money, and they're going to save your health. So I'm so glad that you brought that up, V. As far as whether
Yeah.
they're causing direct symptoms of breast tenderness and stuff like that, I can't answer that because I'm not certain of that, but I can tell you they wreak havoc. And that's why
Well,
I've lingered on this, answering this question for so long.
if you test via, I'm going to get to that question in a sec, but just here, if you test, will the person that's testing be able to differentiate between what a xenoestrogen is and estrogen? Or does it just show up as?
Well, they don't, when you're measuring estrogens, the xenoestrogens do not show up. But the moral of the story is this question takes us to a very important life choice. And the life choice it takes us to is be very, very careful about what you're eating, drinking, and what your normal things for many people are very normal household choices that you make. What you're using is cleaning fluids, the dry cleaning you're doing, what you're using is your laundry soap, all this stuff. I went to a conference and I went into this lovely Airbnb just last weekend. I walked into the Airbnb and there was this perfume order in this place that was off the charts. And it was on the sheets, it was on the pillows. I walked into the bathroom, there was 3 major cleaning things in there. And as lovely as this place was, I went, oh God almighty, what did I walk in here to? An unhealthy environment. You can smell it. And so that's what I want people to remember is save yourself some money. Clean your house with in a spray bottle of water and clear distilled vinegar.
It works really well.
And if you need to scrub some pots, use some baking soda. It works really well.
It reminds me of my
Now tell me, what
grandmother.
else do you need? Well, you need things to put in your washing machine and things to wash your dishes, but there are companies and they put out these free and clear products Choose those, and then you're done. You don't need all the rest of that, all those bottles and cans. So I'm going to stop. Get off my
But thank you so
soap.
much. It's really so important, Dr. Rosensweet, it is. And also that the skin is a big mouth, so to speak. So you get in the bathtub with all these perfumey, whatever's, and that gets in too. So,
Hair products. Oh my God. And the biggest elephant in the room is the food supply, because you don't taste the xenoestrogens and other poisons that are in that food that they've used to kill insects and weeds. If you're not purchasing organic food, you don't taste it, but it's there.
yeah, right, right.
So
Oh,
since
huge.
so there we go. I'm going to step down off my soapbox and let's move on to the next question.
Okay, but it's not a bad idea for another interview for another day, for sure, because I think it's very important. Second question comes in, and I can combine it with another one. My legs swell terribly when I take oral prometrium. My doctor will not allow me to take it. I thought it was just estrogen that would cause swelling of the legs, and I'm very confused, and I'm not sure what to do because I know that I need progesterone as well. I'm very concerned about clots. I'm going to add this in too because it's another question, but she says, I've heard a lot about coagulation, but I thought clots were much more of an estrogen issue, not a progesterone issue.
Ooh-wee.
I know, huh?
I'm saying we because a couple really important questions asked here. We've got an echo.
Okay.
And so one is around coagulation, and the other one is around a woman experiencing swelling when she's taking prometrium, and that doesn't make sense. Well, I'm going to start with the prometrium issue first. It doesn't make sense. Progesterone has diuretic effects. So when a woman goes into perimenopause and she starts taking progesterone, I'm not going to say prometrium, she should have some of that swelling resolved. And yes, you can get into excessive swelling if you have unbalanced estrogen effect. Excessive estrogen can cause swelling as well. So her basic concepts are correct, but something's not right. So what do? We do what we always do. We take an extensive medical history, just look for clues. And from really understanding the patient and turning on the metaphorical microscope onto that individual patient, we come up with our first ideas. Well, prometrium is a late player on the block. I mean, bioidentical progesterone, a molecule that is identical to the progesterone that your ovary put out, has been around for 40, 50 years. And that's different than prometrium. Yes, prometrium has micronized bioidentical progesterone in that capsule or whatever that is. But for years, it's been put into peanut oil. If you read the list there's dyes in there, there's heavy metals in there. I am not a fan of prometrium. And not only that, when they came out in only 2 doses, 100 milligrams and 200 milligrams. Well, that's not how we approach giving a woman progesterone. For one thing, we start all the women, especially in the perimenopause, on topical progesterone. Apply it to your skin. And yes, it is true that many women need more. And so sometimes we're going to switch to oral progesterone, but when we do that, we use compounded, bioidentical, micronized progesterone coming from compounding pharmacists. And what I always do is I always order a bottle of 30 capsules of 25 milligrams of micronized progesterone and a second bottle of 50 milligrams. And we'll start most of our patients on 50 milligrams, have them do that for a while, and then gradually increase. 75 milligrams, have them do that for a while. 100 milligrams, have them do that for a while. 125, we keep on jacking it up until they get progesterone overdose. So they take progesterone at night because progesterone can help with sleep. And if you wake up in the morning groggy, like you took an overdose of a sleeping pill, you went too high. So then we back down. Women are so individual. We have women, the most common range that women finally land at when we're doing oral progesterone is somewhere between 50 and 225 milligrams. But the most common is somewhere between 50 and 150. Well, there's a wide variety in between 50 and 150, or sometimes higher. I don't want to use something that's in peanut oil or that has heavy metals or food dyes in there. So we don't do it. Now, a lot of people do prometrium because insurance pays for it. But something's wrong. The mixture between the hormones you're taking, there's some reason why you're swelling. And so we start from scratch and we figure it out because there are so many, women are so individual as to how much you need of any hormone, how sensitive you are to anything that you're given, what the hormone internal balance is between the 4 ovarian hormones, estrogen, progesterone, testosterone, and DHEA. No problem. We just individualize. And we don't start by this blast of 100 milligrams or 200 milligrams of my non-favorite progesterone. We start with low doses of, like I say, some women will start them on 25 milligrams. Some women have special sensitivities to progesterone. Some women have paradoxical effects to progesterone. And that's where I'd start, because the most common effect of a given hormone or medication is the most common effect. But there's such a thing as a paradoxical effect. What that means, you expect progesterone to be a diuretic and not to have you swell. But if one common cause is there's something called a therapeutic window. This is too low, this is too much, and this is the therapeutic window. You gotta hit the individual patient's therapeutic window, and you gotta individualize. And when you go outside the therapeutic window, too much or too little, you start getting these paradoxical effects. They don't make sense at all. That would be my first guess, that she's getting a paradoxical effect from an inappropriate dose. But I want to take us back to scratch. I don't start with 100 milligrams of prometrium or 200 milligrams of prometrium. I start it in combination with estrogen and even testosterone, and we don't begin to design that initial entry into treating a woman in menopause until we've done a very thorough due diligence through an extensive medical questionnaire and an interview with the patient. So you start from scratch again. That's the remedy, because something's off, and a lot of things are off. So you start from zero again, and you figure it out. And that's how we do it. And it's very, very rare that we don't figure things out. Being willing to put our shoulder to the wheel and focus in on the individual patient and really discover what their individual situation is. And it's not even rocket surgery. To someone who does this day in and day out, I think it's fun. And women often show up at a healthcare provider's office or on virtual, and they're confused and they're uncomfortable and they've done a lot of trial and error. And I have sympathy for that, because who in the heck wants to have trouble? But it's very common, because if you don't get these are the most powerful biochemicals in our body. You don't get these things right, you don't get that balance right, you're going to have trouble. So the moral of the story is find someone who knows what they're doing and get on their train. And you notice so many questions that come to us. I say, yes, you need the expert. You need someone who knows how to administer these most potent chemicals that are in our body. They have effects. You can feel them. You take vitamin C. It's so essential for us, vitamin C, but you're not necessarily going to notice it. At most, if you take an overdose of C, you might get some loose stools, but you're not going to notice, wow, I feel so much better. Or, oh, I don't have breast tenderness anymore, or anything like that. You're not going to notice any of that stuff. My hot flashes went away from vitamin C. No, you're not going to have that happen. But these hormones are so powerful, you are going to notice them, especially if they go awry. So the job becomes the same. Got to start from scratch. And your first and major job is doing some shopping to where you find someone who's taken on the additional education and really is saying to the public, listen, I treat women in menopause with compounded bioidentical hormones, and it's a special interest of mine. And I've got the education, I've got quite a bit of experience, or I'm getting mentored right now. That's your job. Coagulation. Coagulation is an issue, period. And when you look at the biochemistry and the biophysiology of how blood clots or doesn't, oh my God, it's so complex. There are so many steps. And I remember encountering that. They didn't lay coagulation on us until I was a senior in medical school. That's very unusual to have such an important topic not show up till I was a senior. And when they first introduced me to it in hematology, and I saw what the complexity of the coagulation mechanism, I was floored. I was so fatigued of more academics, and here it was, a whole new body of knowledge to learn because there's so many steps. Because it has to be very profoundly and exquisitely balanced, and it got to be spot on. Because when there's a cut or a javelin wound, we need to be able to clot. We need to be able to move the whole blood thing over to the ability to clot. And yet we don't want to clot too easily. When we're walking around, we don't want to clot, so there has to be the anti-clot. There's the anti-clot and there's the clot, and they're delicately poised, and there's a lot of moving parts. And what does it turn out? The American population should be delicately poised. Not so. It's skewed. That means a huge number of Americans are skewed. They have an increased propensity to clot. That's problem number one. And it's big. And when there's viral infections, you have an increased propensity to clot. And what's happening to COVID people are having the most severe consequences. They're clotting in their lungs because the germs are eliciting one of the most primitive of germ fighting mechanisms. You clot these germs up. You throw glue around them, the clotting mechanism, which means that when someone has a huge viral infection, they have an increased propensity to clot. Just give me examples how all this works. So Americans are not perfectly poised. For a variety of reasons, they skewed over to an increased propensity to coagulate. This coagulation is such a significant issue that we have a whole segment in our training program on coagulation and how to test for it. That's the general background. Coagulation and hypercoagulation is an issue. You know, half the people who leave planet Earth leave through the complication of arteriosclerosis. They've got arteriosclerosis in their coronary arteries, or they've got arteriosclerosis in the arteries that feed the brain, and they die from a heart attack or stroke. Half the people who leave Earth in the United States. Why is that so? And they don't die from the arteriosclerosis. They die from the clot that is triggered by the irregular surface of an artery. That's a provocateur for a clot. If you've got a barnacle-laden internal arterial surface, that will provoke a clot where a smooth arterial surface will not. It's the clot that's the issue. When you hear people die of a heart attack, most of them are dying from a clot that formed in that artery. So coagulation is a big deal. As it relates to female hormones, we learned when the birth control pill was invented that a certain small percentage of the women who went on birth control pills got a clot in their leg veins. It's known as a DVT, or deep venous thrombosis, from taking the birth control pill. The birth control pushed their clotting mechanism over the edge, and they got a clot in a vulnerable area where the blood moves slower in the deep veins of the leg. Sometimes those clots broke loose and went to the lungs. They had something called a pulmonary embolus. Oral administration of the estrogen in that birth control pill was the problem. Oral estrogen. And theory says that that's solved by giving people topical estrogen. So the only thing, I've given oral estrogen to one patient over 25 years of specializing in treating women in menopause. I treated one patient, and my mother just couldn't handle the topical stuff. She had cognitive issues. Outside of that, I never prescribe oral estrogen because it's known to provoke coagulation. It's known to provoke inflammation and coagulation. And a lot of it is you got to use a lot higher doses when you administer a hormone orally, because when the hormone goes into your intestinal tract, it then travels directly to the liver. And instead of traveling directly to the whole body first, it goes to the liver first. That's called first pass through the liver. And about 80 to 90% of it is metabolized. So it never makes, so you got to use higher doses to get the 10% through to the rest of the body. Now, having said that, there are exceptions. There are women, I've had two patients, Nancy and Denise. I remember their names many, many, many years ago. I haven't seen this for quite a while. That I had them on topical, biased, and progesterone, and they both reported to me that, not at the same time, that they were having uncomfortableness in their legs like they had when they took the birth control pill and they got their clot and their thrombophlebitis. Well, we investigated that carefully, and it turned out that it wasn't caused by the topicals. They eventually tolerated the topicals, but it did raise concern, so you never say never. And my guess is, had I been doing the sophisticated coagulation profiles, that I would have seen enhanced coagulability in these women. So coagulation is an issue, and hypercoagulation is the real issue. Theoretically, you're going to be safe if you use topical and you don't use oral estrogen. But you never say never in medicine, and occasionally something comes down the pike like increased coagulation, but we're going to get clues about coagulation issues most likely. And when we get those clues, we do a very sophisticated coagulation workup. We do blood tests that tell us whether a woman has an increased propensity to clot. But the main thing you want to know is avoid oral estrogens. It's not supposed to happen with oral progesterone, but in medicine, I never say never. If this particular patient had an issue, well, we do the same thing we always do, always. We begin with a 12-page questionnaire. It's now on an app, so it's not on pages. And but it takes half hour, 45 minutes, even an hour to fill it out. During the first consultation, the healthcare provider goes through line item by line item by line item. And when we're done with that initial evaluation of reading through that questionnaire, man, do we know a lot about that patient. And it gives us the clues of what requires our attention. And sometimes we have to take sidetracks. Sometimes we see things on that initial medical history that make us go, well, we're not going to start you on hormones today. We have some initial investigation we want to do, and we'll do it, but we'll get there. Don't worry about it. And what do I see? Something like, my mom had a stroke, my father had a stroke, my grandfather had a heart attack. We're seeing an increased propensity to coagulate in the family history, and we're not going to leap into doing something until we sort out that bottom line issue is, are they hypercoagulable? So we know how to test you to do that. And the great news is even people who are slightly hypercoagulable for not severe reasons like major infections or stuff like that, there's so many great easy remedies. Like there's many people, I can give them enough fish oil, which is good for them anyway, and vitamin C and vitamin E, their clotting mechanism is going to disrupt it to the point where they're going to get bruises on the back of their hand. And there's very many people that we slow down their clotting propensity to clot or their excessive propensity to clot just by giving them omega-3, vitamin C, and vitamin E. Sometimes we add these special enzymes that come from earthworms, for example, lumbrokinase. These things will slow down those who are hypercoagulable. We can use such natural things. Sometimes we'll go to medications. We do whatever we do. When we see a propensity to hypercoagulate, that's a medical thing that really requires attention, just like high blood pressure does or high blood glucose does. We want to deal with this medically. And we learn about it and we deal with it all the time. And I've talked about this before. When a woman has so much protection from estrogen. Her coronary arteries are so protected from estrogen. You don't hear of a young woman in her 40s keeling over from a heart attack, never been sick in their day in their life, unless they had a clot. You don't hear about that. You do hear about that occasionally in young men. It actually happens. The incidence of coronary artery disease is lower in young women than it is in men, and that protector is estrogen. That incidence equalizes by the age of 60. What's the difference? No estrogen. It's a big deal. Estrogen is so amazing for protection of arteries. It's one of the reasons you want to get on the train as early as you possibly can and keep your estrogen levels good for your whole life. Protection of those arteries. So, once again, I know I'm diving deep into the weeds, but it's such an important question, such an important topic that's why I wanted to go there. And the remedy is the same remedy. If you're in your 30s or your 40s and you're starting to get squeaks in your period, or you're starting to get some symptoms that could relate to low ovarian hormones, it's always the same thing. And this is the only thing, women tuned into this Facebook Live, it's the only thing you really need to know is you need to go shopping and find yourself a healthcare provider who's taken on the special interest of treating women in menopause with compounded bioidentical hormones. And now in these days of telemedicine, you don't have to see this person, and you can see them virtually. So you have access to anyone who's licensed in your state. And believe me, this is mushrooming. I mean, I've only practiced by telemedicine now for 12 years. And so long as you have your primary healthcare provider who can see in person for things that you need to see in person, menopause lends itself beautifully to telemedicine. So your job becomes the same. Find someone who's expert. You can increase your ability to be able to identify an expert. I recommend you read Happy Healthy Hormones. Carolyn's made it available for no charge, the PDF version on the ins and outs of menopause. It'll give you a certain education. I wrote that for women because in this day and age, unfortunately, I think it's important that women have a certain amount of information. Once you see what a proper approach to this is, you'll know how to go shopping. You'll be able to ask them some questions, the office manager questions, when you talk to the office manager on the phone. Does your doctor do this? Does your doctor do that? If you've got a doctor that's doing 24-hour urine hormone testing, man, that's a huge clue. They have really cared about this. They're really into it. That's quite a learning curve for them to do that. So, yeah, coagulation, it's an issue.
Well, it is indeed.
Yeah, we do whatever it takes. If it takes aspirin, if it takes anticoagulants, we go all the way because this is an important thing until you sort out what got you hypercoagulable in the first place. So you can take hormones and have a hypercoagulable state. You just do it right. So you go to someone who really knows that this is an important part of evaluating women. And by the way, it's quite uncommon, especially for women who they're catching this in perimenopause or early menopause. Coagulations can be an issue, but it's very rarely an issue. If you catch you catch it while you still have the protection of your own estrogen, or you're hopping on trained in getting estrogen protection early on in your menopause, that's what you need to do.
Right. And then just to throw it in, which is a beautiful thing, we can tell our children about it too, because many of us were not told anything about anything having to do with menopause. And they do is hush, hush. Mm-hmm. So we can also pass your amazing information on and eventually hope to heal the world, you know? Certainly. So thank you very much, Dr. Rosensweet, for that. An interesting question has arisen, and it says, does the 24-hour urine test show if we are at a risk for cancer? I thought that I heard Dr. Rosensweet talking of certain enzymes we need in order to be safe. Would these enzymes be shown in the 24-hour urine?
Another excellent question. Cancer. What kind of clues do we have that we're at risk for cancer? Cancer is a very intense illness. Searching a little bit for the word there. Sometimes lethal. And when we stop to think, well, how in the world did this person get cancer? It isn't because of the hormones. People don't get cancer from hormones. Think about the level of hormones in pregnant women or young men. Hormones don't cause cancer. I'm pausing there because people got so scared as if hormones cause cancer. But the information that scared everybody was false. And yet the press got a hold of it and exploded it out onto the American public like nothing I've ever seen happen in medicine. Nothing. And it was a Women's Health Initiative study in 2002, and it got published, and it shouldn't have been published because the increased risk that someone read into the study was not a statistically significant increased risk, so it never should have been published. And it says it right there in the original Women's Health Initiative. The increased risk with Prempro, 1.26. 1 means there's no increased risk or decreased risk. 1.26 is a very low number. And it's well known in science that 1.26 is not statistically significant. And they stated it right there in the Women's Health Initiative, but it seems like the press missed that one and just said there was an increased risk. They didn't include, but it was statistically insignificant. Well, the study should never have been interrupted and published, because when you have statistical insignificance, you got garnished. You got nothing. And there were many on that original study committee that objected vehemently to that study getting published because they said it's statistically insignificant. This lab will have an adverse effect on the public. And indeed it did. And someone overrode them, published the article anyway. And of course, that original study committee retracted the Women's Health Initiative, publishing in the same journal that the original one was. And they said after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke. 18 years later, they admitted it. So, I'm going to get myself back into the actual question, which, oh my God, what was the original question, Carolyn?
I got to find it. No. Does the 24-hour urine...
Yeah, right, thank you.
So,
that's what's happening.
Not a problem.
So, even horse urine-derived estrogens combined with a progestin, which is a very funky molecule that's very problematic, Look up Phyllis Bronson, who's done some wonderful research on this. Even the women who were treated with Prempro had less risk of breast cancer, heart attack, and stroke than women who were not treated with Prempro. Hormones don't cause cancer. Now, let's go to the 24-hour urine. Here we are, we're treating a woman in menopause, and we're assessing her hormone levels, and in my opinion, nothing does it better than the 24-hour urine hormone test. And several things are measured on the 24-hour urine hormone test. The actual hormones themselves, like estradiol, estrone, estriol, progesterone, testosterone, DHEA, cortisol, cortisone, those are the actual hormones. Then there's when hormones interact with the body in receptor sites, they get biochemically transformed into something called metabolites. They don't maintain the same biochemical configuration after they did their thing. In fact, the liver converts them, for example, into these things called metabolites. So your estradiol or your estriol goes in and does its thing, then it gets picked up by the liver and it gets biochemically transformed and excreted in the urine and in the feces. And how you excrete something is you have to do something to it. And that's one of the main things the liver does to hormones, is it takes the estradiol and the estriol and it converts it to these things called metabolites. Now, one of the things that we don't think is a good thing to do is to treat a woman in menopause with hormone dosages that are higher than when they were young. That's being done. We don't believe that's a good idea. We think a menopausal woman should not be given youthful levels of hormones. For example, youthful levels of estradiol is going to cause what young women have happen. It's going to cause their breast glandular cells to proliferate, undergo mitosis. That's a very vulnerable thing in a 50-year-old. It's a moment in time when we want to have a very safe environment for that cell division to take place, and we want to have an immune system strong enough to pick up glitches that can take place during that very vulnerable time. So we don't think it's a good idea for a woman in her 50s to give so much estrogen that she gets breast glandular cell proliferation. Young women have ample estrogen that every single cycle they get breast glandular cell proliferation in preparation for possible lactation should they impregnate. It begins right there every single cycle before the impregnation. You get extra cells. And women know this because their breasts get fuller. If they don't get pregnant, their breasts get less full as they go into their period. Breast glandular cell proliferation, well, we think that those levels are too high. So one of the things we're checking for in a 24-hour urine is that the estrogen levels aren't too high. And the testosterone levels aren't too high, and the progesterone, we check to see that we're not over-medicating, we're not overdosing. Not really medications, they're bioidentical hormones. Because we don't think it's a good idea. Now, there's always exceptions, and in medicine, you never say never. There's some women who do need youthful levels, robust levels, higher than youthful levels. If there's cognitive challenge, one of the first things we do is we're going to keep on raising that estrogen because a lot of women will clear up. And some women get their periods back when that happens. These are rare, but you do what you need to do to restore cognition. And if estrogen will restore cognition, you do it, you get it up high, and women gets her period back, even it can go that high, and you monitor the breast like we do in every patient through proper usage of the many breast imaging tools that are out there, and they're all radiologic. Yes, we use thermograms, but not as a cancer screening. No. So there's a lot of moving parts to medicine, and I don't want to overwhelm people. Now, there's this other thing that happened in the 24-hour urine, and there's an association of the metabolites, what the hormones become in the process of being transformed and excreted. And there's youthful common levels of what patterns you see. And then sometimes you see patterns of metabolites that these aren't youthful levels, these aren't healthy levels. And the metabolites have been ranked. And for example, the most favorable metabolite of estrone and estradiol is 2-hydroxyestrone. And it used to be thought that at least a lesser favorable one was 16-alpha hydroxy. That's another pathway that you can take. I know these are foreign terms, but they're different metabolic pathways and they're different metabolites. And that's been questioned severely now. I just attended a seminar again, and they're no longer believing that the 16-alpha hydroxy is that provocative. And then there's the 4-hydroxy. And you know, that's not commonly elevated. And when it's commonly elevated, you wonder what's going on. That one has been the one that we question. We don't like to see it. We like to see normal metabolites, but whether it's going to cause cancer or not, my God. When you think of causing cancer, I like to think of this, that cancer, like any illness, has causes, definitely. And they fall into 5 categories. Adversities of nutrition, what you're eating, breathing, and drinking. Issues of toxicity, poisoning. Issues of too little or too much exercise. And the elephant in the room is a dysfunctional response to the stresses of life, where you get bent out of shape and you really want to have a more effective, positive response to life stresses, because life stresses are important for us. They're a healthy part of life. And then there's a 5th one, mysterious. You have an infant that's born and lives for 5 days. You don't necessarily know how in the heck that happened. There are mysterious causes. There's mysterious causes that we don't ever figure out why someone died. But most of the time, and what I like to say is, when a person has a serious diagnosis, I say, let's pretend a videographer took a video of you from the moment you were conceived, intrauterine, till now, 24/7. And they were fantastic with editing, and they had a magic editing button in which they pressed that button, and all the good stuff disappeared from the footage. All the happiness, all the good meals you ate, all how clean a lifestyle you lived. Just beautiful things happened. They're all eliminated. What would be left behind would be all the challenges of nutrition, toxicity, exercise, stress, and the mysterious that you did not, that were there. That's how these serious illnesses occur. They don't occur by one biochemical pathway with a natural hormone process. That's my own opinion about that. And is there an association? Well, it's not super clear, but there probably is an association. But it's minor. It's one of the myriad of causes that can occur. So it's complex. When we see abnormal metabolite issues, the first thing I start questioning is, why are they getting unusual, non-usual pathways occurring there? It's usually an issue of the liver. And people have liver challenges. People have given their liver a rough time. And if the liver's having a rough time, man, you want to look at the intestinal tract, because the liver is downstream metabolically from the intestinal tract, and there's a lot of stuff that can happen in the intestinal tract. So what we suggest is that they link up with a functional medicine expert in how to assess and address liver and gut stuff, just for openers, when we see abnormal metabolic pathways, because it's not a healthy thing. Though we live with a lot of internal tweaks, so there's much more governing life itself and health itself than meets the eye, as Carolyn and I went into last time, and the magic hour has arrived.
Dr. Rosensweet, dear Dr. Rosensweet, I wish you an amazing weekend. I am going to repost our interview that we visited all of the psychology back of menopause because it went way down on the page, so women aren't really seeing it. But I'm going to repost it because it's very, very, very interesting. The bewitching hour is here. No more questions for us answered, but we will see you on Tuesday. Happy weekend to all, to you. Thank you, Dr. Rosensweet. And may everybody have a wonderful, love-filled, non-stressful, we hope, next few days. And we will meet up again on Tuesday.
Thank you, Carolyn.
Thank you, sir.
It's always a pleasure.
Always a pleasure.
Yeah.
Indeed. I don't know what I'd do with my weeks if I didn't have these mornings.
Yeah, I'm sure.
Goodbye, everybody. Enjoy, and we'll see you on Tuesday.
Yeah.
Thanks for being